Hello everyone, a warm welcome to all those interested in sleep medicine and sleep research to our second episode of Sleep Lab with Netzer and Popovic.
A warm welcome from me as well, and we'll get right into it. And as we promised, today we'll be dealing with more concrete topics related to sleep. We'll start off, so to speak, with the question of how a sleep disorder can actually be recognized.
Yes, although we have to admit that things change every day, so technological progress never stops. And in this context, we are also grateful to have two supporters for this program. First, and this also explains the logos in the background, the company Ingenieurbüro für Medizintechnik, which supports us with technical questions for this show. And secondly, the Federal Association of German Sleep Medicine Specialists, which supports us with professional expertise and for which I have the honor of serving as the second chairman.
The question you naturally have to ask yourself is whether or from when a sleep disorder actually requires treatment. If we've been out celebrating too long, or there's some reason why we're not well rested, a long car ride or something else, it's completely normal. But when a sleep disorder truly requires treatment is something you'll hear from us in this episode.
Yes, we assume that a sleep disorder has to directly bother a person. So if I sleep badly twice, but don't see it as a problem, there's really no reason to go to a sleep specialist. So we're really talking about something where you say, wow, this is lasting longer, it's annoying, I need to do something about it.
Of course, sleep apnea is especially well known with its characteristic symptoms like when the person next to you in bed snores loudly and the other person in bed is disturbed by it. But there are also conditions where we have involuntary movements during sleep. That means it can even go so far that you might fall out of bed or move very irregularly, or your legs start moving, and all of this happens involuntarily during sleep.
Yes, as Raina already mentioned, if you not only snore loudly, but so loudly that you can hear it in the next room, or if your bed partner says you make these gasping sounds for seconds or even minutes, then it's probably time to see a doctor. Another important reason could be, for example, if you have very restless legs, so much so that you almost trample your bed partner with your legs at night, you could say. Or if you have the feeling that you can't fall asleep because you have this tingling like ants crawling in your legs, that would definitely also be a reason to visit a sleep lab or a sleep specialist, and perhaps as a first step to consult your general practitioner. And there are already some things you can do in advance to make the work easier for our colleagues.
You've already described the symptom of tingling legs and restless legs during periods of rest. That means when you go to bed or even just sit in front of the television in the evening, we're talking here about the so-called restless legs syndrome. This syndrome might not even be the classic case in a sleep lab. That means just from the patient's description alone, the doctor can already arrive at a diagnosis, but more detailed information can be gathered during the stay in the sleep lab. Well, life is made easier by questionnaires, and now we're coming to the topic of questionnaires.
I'd like to introduce these questionnaires to you now. We'll take 3 of the most important questionnaires and actually start with the oldest one, which basically assesses daytime sleepiness. This is the so-called Abworth Sleepiness Scale or Abworth Questionnaire. Abworth is named after a city in Australia, and it is generally used by most general practitioners who deal with the topic of sleep medicine at all. And of course, you have the option to download this questionnaire from the internet, take a look at it, and if necessary, fill it out before you go to your general practitioner. I'd like to briefly introduce this questionnaire to you now.
The questionnaire, simply referred to as Epworth by medical professionals, is a self-assessment form officially called the Epworth Sleepiness Scale. It was published in 1991 by the Australian traffic medicine specialist Murray Johns and named after his clinic in Melbourne. It is intended to provide information about the degree of daytime sleepiness and was initially designed primarily to identify tired drivers. Sleepiness is assessed in 4 levels of severity, from 0 to 3 points, ranging from not at all to severe across 8 different monotonous everyday situations. Anyone who scores 8 points or more on the questionnaire is suspected of being sleepier than normal during the day. Other symptoms of specific sleep disorders are not covered by the Abworth.
Now we've gotten to know the Abworth Sleepiness Scale, and as we've seen, it's mainly about sleepiness. As Raina already mentioned, the most common sleep disorder is, of course, sleep apnea syndrome. And for that, it's not enough for us to just ask about sleepiness. We also need to ask further questions, specifically about breathing in addition to sleepiness.
So specifically, I think the next one to mention here is the Berlin Sleep Questionnaire. The Berlin Sleep Questionnaire has 3 parts. First, snoring is questioned, then daytime sleepiness is addressed. But of course, what is also relevant for us as physicians are the risk factors. That means, when do I need to treat a sleep disorder? And for that, I need to know whether there are other illnesses or risk factors present. But it's very important not to forget here that we have to distinguish between a screening questionnaire and a diagnostic tool. That means one questionnaire serves as a diagnostic tool, which allows me to at least suspect a diagnosis, while a screening questionnaire is only intended to help determine whether such a disorder might be present.
Yes, but the Berlin questionnaire, as mentioned, is one of the most commonly used questionnaires, and we want to briefly go through it now. Of course, you can also find this Berlin questionnaire on the internet, download it, and bring it with you to your appointment with your general practitioner. And now let's take a closer look at the questionnaire.
The Berlin questionnaire, like the Abworth, is a self-administered questionnaire that not only asks about fatigue, but also covers 3 symptoms or risk factors for sleep apnea. Firstly, loud snoring and observed breathing pauses. Secondly, daytime sleepiness, including drowsiness while driving and morning fatigue. And finally, being overweight and having high blood pressure. The questionnaire was developed in 1996 in Chicago by the physicians Nicholas Netzer, Ricardo Stoss, and Kingman Stroll, as well as the medical device manufacturer and philanthropist Edward Schuck, and was subsequently validated by 100 general practitioners at a conference in Berlin as a screening tool for family doctors. The answers in the 3 risk categories are weighted differently, and anyone who reaches a minimum score in at least 2 of the 3 risks has a high probability of having sleep apnea.
The Berlin questionnaire is somewhat similar, though a bit shorter and not used quite as often, is the so-called Stop-Bang Questionnaire. And we'll take another look at that as well. Of course, instead of the Berlin questionnaire, you can also fill out this questionnaire and take it to your general practitioner and say, okay, these are what my symptoms look like. That naturally makes the work much easier for the colleagues on site.
The Stop-Bang Questionnaire, developed by Canadian anesthesiologist Francis Chong in Toronto for risk assessment before anesthesia and surgeries, is similar to the Berlin questionnaire regarding the 3 main risks for sleep apnea, but is greatly simplified with only 2 possible answers, namely yes and no, and only 4 questions plus 2 items concerning physical risk factors.
So with the Stop-Bang, if I may pick up on that again, it's actually the case that this questionnaire comes from the medical world. That means it was put together by anesthesiologists because during preoperative preparation, they would unexpectedly encounter problems in the recovery phase if a patient with sleep apnea had not yet been diagnosed or was not receiving any treatment. Because this can lead to sudden alarms during the recovery phase or after anesthesia. And the anesthesiologists wanted to avoid that, so they designed a relatively short questionnaire for themselves, which contains specific questions to identify the presence of sleep apnea.
Yes, but Raina, I have to indulge in a little bit of self-praise here, just a tiny bit. So the Berlin questionnaire, which I helped develop, wasn't created by lay people, but by medical professionals. Yes, the questionnaire was developed in the 1990s in a kitchen in Chicago, yes. But doctors and experts were involved, and that's why it's called the Berlin Questionnaire. It was presented to 100 general practitioners in Berlin to vote on which questions they found most meaningful. That's actually why it's called the Berlin Questionnaire. Otherwise, it should really be called the Chicago Questionnaire. So we are glad to have a questionnaire that's named after a German city.
So it's not just about justifying myself. I never said that the Berlin Questionnaire wasn't created by doctors. I just wanted to point out that the need for the Stop-Bang, which only came about much later, arose from anesthesiologists' need to quickly identify sleep apnea. That's why I specifically mentioned the anesthesiologists.
Yes, of course, for everyone affected and those who are interested, this is very important because sleep apnea and other sleep disorders naturally also play a significant role in the hospital. And that's why the colleagues want to avoid running into problems during surgery by knowing about it beforehand. And as I said, Rainer already mentioned it, the questionnaires are not a definitive diagnostic tool. However, it's still important. If you have a sleep disorder, please do yourself a big favor. Don't just ask doctor Google. Don't just go to your grandma's medicine cabinet and grab the next best sleeping pill. Instead, please go to one of our colleagues, describe your symptoms, and get professional help there.
So I think what you're getting at now is really, really important. Normally, if at all, and unfortunately that's not very often, sleep disorders are first reported to the family doctor. And the family doctor is often overwhelmed, doesn't really know what to do with it, and automatically refers the patient to a sleep specialist anyway. And it's only the sleep specialist who is actually able, and this is the next important point, you mentioned that you shouldn't rely on doctor, Google and the like, but should always leave the interpretation of this information to a professional. Otherwise, it's very easy to fall into the trap of overlooking things or misinterpreting them, and then a lot of nonsense comes out of it. So please, always 7, if you consult Dr. Google. I've always been glad when a patient showed interest and did some research on the internet. But please interpret it with professional help.
Yes, Rainer, on that point, you and I are in complete agreement. People might say that with 40 years in sleep medicine, we're dinosaurs, but we've already shown that we are open-minded and have said that you can download questionnaires from the internet, that it's absolutely fine to get information online. But I think we both agree on 2 points. It really should continue with medical supervision. And as you already mentioned, it's also important, so to speak, not to stop at just the basic screening, what we call sleep apnea screening or sleep disorder screening, but to continue on that path and complete the diagnosis. And I also think on this point, we probably both agree that in the end, you can't avoid spending a night or doing a test in a sleep lab.
It also has to be said that the availability of sleep lab slots is very, very limited. That means the demand would be much higher. But that's why we try to help ourselves and, for example, offer these ambulatory monitoring examinations in our practices. They are already very informative and really provide valuable pre-diagnostic information and should definitely be used. That means you shouldn't hesitate to go to the doctor who can basically give you such a device to take home overnight and already obtain essential preliminary information there, so that the decision to send someone to a sleep lab, and especially how urgent that needs to be, can often already be made using these ambulatory examination methods.
Yes, this next step that Rainer just mentioned, after the initial screening, the first tool, this preliminary examination before a possible visit to the sleep lab, is polygraphy. Let's take a look at a picture together now to see which parameters and which steps are measured there.
An outpatient examination for extended diagnosis of sleep apnea is called polygraphy, in contrast to the sleep lab, where polysomnography is performed. The patient receives the measuring device, which they are to put on themselves at home in the evening, while being supervised during the day in the office of a general practitioner or specialist authorized for this measurement. Among other things, the measurements include airflow at the nose, snoring sounds, body position, oxygen saturation and heart rate recorded via a pulse oximeter, as well as chest respiratory movements. Since sleep itself is not directly recorded, polygraphy is therefore suitable exclusively for accurately diagnosing sleep apnea and does not provide any comprehensive information about how sleep quality is significantly affected by apnea or how it substantially improves during therapy.
So that was a brief explanation of polygraphy. But Raina, I think the two of us with 40 years in the field are probably dinosaurs of sleep medicine, but we do our best to stay up to date, and we agree on one point. This polygraphy, which can also be performed by interested general practitioners who have received special training, should not be the final step. In my opinion, and feel free to disagree, a night in the sleep lab should still be done for a final diagnosis.
That certainly makes sense in most cases, and we'll show you exactly what happens in the sleep lab in the next episode.
Take care, everyone.
And sweet dreams.